Okay. Now we're unmuted and ready to go. Welcome, everyone. We're so glad to have you here with us to discuss a very important topic, prenatal genetic testing. My name is Rivka Freundlach. I am, sorry, we have some background noise here. I currently live in Montreal, where I serve as the Rebbetzin of Congregation TPTJ, as well as the Yoetzet Halacha. And I'm very honored to be here to moderate a discussion today on prenatal genetic screening with Dr. Nady Fox and Rabbi Kenneth Alman. So before we get to our discussion, I want to have the opportunity to introduce them to you more formally, because it is indeed an honor to introduce them to you. Dr. Nady Fox is a board-certified specialist in obstetrics and gynecology with a subspecialty in maternal fetal medicine. He completed medical school and residency at Mount Sinai School of Medicine and his fellowship at Weill Cornell Medical College. He is currently a clinical professor of obstetrics and gynecology at Mount Sinai, as well as a managing partner at Maternal Fetal Medicine Associates and Carnegie Imaging for Women in New York City. For those of us who are not on the medical end, but maybe on the patient, the patient's end, we might be familiar with Dr. Fox from his very successful and popular podcasts, both Healthful Women podcast as well as High Risk Birth Stories podcast is one way that so many of us have had an opportunity to get to know Dr. Fox, to hear his wisdom and his wit. So we are very grateful to have Dr. Fox joining us today. And we are also joined by Rabbi Kenneth Alman, who has been the rabbi of the Young Israel of Flatbush and has been serving there since 1984. Additionally, Rabbi Alman teaches Judaic studies at Stern College, and for the Yoetzot, the following is our most precious title that Rabbi Alman has, which is that he is the Dean of Nishmat's Miriam Glaubeck Center for the Training of Yoetzot Halacha in the United States and Alad, Canada, since that's where I live. Rabbi Alman, aside from being a tremendous source for and resource for halacha, is a unique combination of the world of Torah and the world of human beings. And as someone, I know that he doesn't want me to say this, but I can't help myself if I have an opportunity to share that on behalf of the many, many women that I have had the opportunity to consult with. And I'm sure I say this on behalf of all of the Yoatzot, that we are so grateful to Rabbi Alman for his, not just his Torah knowledge, but his sensitivity and his ability to bridge the two worlds of real life of the people who are trying to live the Torah, as well as the Torah itself, and the bringing together of those two worlds. So it is really an honor to be here with both of these distinguished gentlemen with you today. The way that we're going to run this is that I will present two case studies, and we will both hear from Dr. Fox from the medical end, as well as Rabbi Alman on the halachic end. I will pose some questions, and we welcome your questions as well. They will be fed to us through private chat that we have, so don't worry if you're not seeing them. We will hopefully see them. We thank Lisa for manning our technology from behind the scenes, and we look forward to delving into this topic with you and hopefully getting you some great information and answers to your questions. Let's get started. Okay, our first case. Leah is a 27-year-old woman who is 10 weeks pregnant. So she's 27 years old, 10 weeks pregnant. This is her first pregnancy, and thus far it has been going well. She and her husband, Sam, married a few years ago and did not have any difficulty conceiving. Neither carry any genetic conditions. Leah and Steve grew up Orthodox and are members of an Orthodox shul, but other than keeping a kosher home and coming to shul every now and again, they are not particularly observant. Leah's obstetrician recommended that she have a blood test and ultrasound to screen for Down syndrome and other genetic conditions. She and Sam are uncertain about what to do, as they disagree about whether they would have an abortion if the results were abnormal. So I'd like to please turn this over initially to Dr. Fox to ask you, what would you advise Leah and Sam regarding screening, given their situation?
Yeah, thank you so much, Rifki. Also, thank you for having this. Thank you for hosting. Thank you to Nishmat. Rabbi Alman, it's an honor to be with you. And thank you to everyone for tuning into this amazing event. In terms of the case, it's really interesting because when women come to me in similar circumstances, around 10 weeks pregnant, they're otherwise young and healthy and no particular issues walking into pregnancy, I actually don't tell them that I recommend they do genetic screening for Down syndrome. And so I think that sometimes either the obstetrician does say that to the woman, and I might disagree with how that's phrased, or sometimes it's just what she hears, meaning it's not actually what was said. And so when I speak to women about genetic screening in pregnancy for things like Down syndrome, what I basically try to convey to them is that it's really a choice and there's options with what to do. Ultimately, when we're trying to see if the baby has a genetic condition or not, there's nothing about that information that's going to make the mother healthier or the baby healthier. It's information. And there are reasons people would want to know that information before they deliver. One of them might be if it's going to lead to a termination, but there's many other reasons someone might want to know. That could just be in terms of, for most people, since most people don't have babies with genetic abnormalities, they get reassurance that everything seems to be going well. And if they have a level of anxiety over this, the testing or the screening can lower that risk. Another reason might be if it happens to be that their baby does have some sort of genetic condition. They can learn about it. They can find out more about it. They can decide, do they need to deliver it at a specific hospital or meet with certain doctors beforehand? So it's not always about abortion. That really it's sort of the elephant in the room, but it rarely is actually in the room because most people have normal results. And even those with abnormal results, it doesn't have to lead to that. And so what I tell them is essentially you have three options. You can either do nothing, say I'm not going to do any screening. I'll wait till the baby is born and we'll sort it out then. And most of the time, someone her age with her history, over 99% of the time, that's going to go fine. Baby's going to be okay. That's one option. On the other hand, they can go in the totally other direction and say, you know what? I want to know everything humanly possible about this baby before birth. I want to know every single thing that I can that's normal. God forbid there are any abnormalities. I want to know about them. And the most advanced way to do it is actually not with screening, but with testing. to do like an amniocentesis or a CVS and to find everything out. And then in the middle, there's this idea of screening where there's certain blood tests we can do and ultrasounds we can do, which sort of give you a sense numerically what is the risk of having a baby with certain conditions, which if normal might push you towards the I'm not going to do anything more side, versus if quote unquote abnormal or higher risk might push you more towards the invasive testing side. And so I basically present those three options: do nothing, do a full test, or do the screening in the middle, and then talk about which of those options is most appropriate for her or for that couple. So in this particular situation, I would throw it back at her and ask her, what is she looking for in this situation?
Okay, thank you so much. It's very nice to hear from medical practitioner that they're handing over so much of the input to the patient. So thank you for that. Rabbi Alman, can you share with us perhaps what you would do in this situation if this couple were to come to you after they've been given these choices by Dr. Fox? What does halacha have to say about this?
Well, so first of all, thank you very much for having me on this panel. It's a great honor to be here, and again to be with Dr. Fox, with Rivke Freundlich, one of my star students, and again, I think this whole program of Nishmat, it's a wonderful, wonderful program. In any case, this is our particular question. So first of all, it's important to understand from the rabbinic perspective that you can't have a proper rabbinic answer to anything without having the medical input first. So what Dr. Fox says is crucial to answering the question, because really you first, in order to make any kind of a halachic decision, you have to have all the facts in front of you. And when you're dealing especially with medical issues, the doctors are the best people to understand and present those facts. So at first, the first thing we always do is see, is there a medical recommendation one way or the other? Now, Dr. Fox is telling us that in this case, he really presents and feels that all the options are equally valid. So there really is no medical preference one way or the other. Am I correct, Dr. Fox?
There's no medical preference one way or another based on how the patient is feeling. However, if she said to me, I do want to know, and it does mean a lot to me to have this verified and to understand, then we would go towards either the screening option or the invasive testing option. For most women, particularly young, healthy women, they choose the screening option because it's less invasive. There's no needle being stuck in their pregnancy. It's less risky. I hesitate to use the word risky because, first of all, it rhymes with Rifki. I just realized that. But secondly, because, you know, when you do an invasive test like a CVS or an amnio, the risk we're talking about is well under 1% of losing the pregnancy from it, probably 1 in 500. So there's risk, but it's hard to know if that number you would really try to scare people away from it. So if she said to me, I really want to know, it's something I'm worried about, then I would tell her she should probably do one of the two, and most likely she'd end up doing screening.
So, okay. So this is, I guess, then a combination of the patient's feeling plus the medical input would determine what. So I would have, from a halachic perspective, in a case like this, there's very, very little to add. The two halachic issues that could come up in this in this kind of a question are, A, the general, you might say it's not really even a halachic so much as a more Jewish outlook of, should people worry so much? In other words, is it right for people to worry? Should we be, should you validate? Should you try to discourage someone from having these kind of worries? Besides the fact that it's probably very hard. If somebody's worried, the worst thing you could tell them is don't worry. That's the worst thing you could tell a person who's worried is don't worry, right? So I don't think discouraging people from worrying is going to help at all. But purely from the point of view of Jewish philosophy, should we worry or should we have faith in God? Right? That's a general question that often comes up. It's in the Hebrew terms would be, on the one hand, bitachon versus hishtadlus. Should we be doing our best or whatever, or should we just sit back and let God take care of matters? Now, normally we don't say we sit back and do nothing. Obviously, otherwise we have to earn a living. We have to be responsible. We have to go to doctors. We have to take care of ourselves. We're obligated to do these things. We're not supposed to sit back and say, I trust in God, and that kind of thing. But on the other hand, when you deal with things where there's a very nebulous or where there's a very small risk, then a person has a right to say, I don't want to do anything. I trust in God, let God handle things, and that would be perfectly acceptable. On the other hand, if a person feels more anxious, there's no reason to discourage a person from a halachic point of view to getting the screening, certainly. Even the more invasive tests, if Dr. Fox tells us that the risk is really minimal, then probably from a halachic perspective, there's no problem doing that either. If a person isn't worried at all, then for a doctor to recommend that they do these, again, even though there's very minimal risk, why do even something with minimal risk if the person isn't worried about it in this case, and there's no real medical need to do it? But if the person does have some anxiety and wants to know for sure that nothing is wrong, and feels very anxious, I don't think that there would be any problem doing it, even if there is a minimal risk, because again, it's very minimal, and people do all kinds of things with minimal risk in this world. So I think that either any of these options would be halachically okay.
I think actually that's really reassuring to hear on my end, because what happens is frequently there are doctors who tell people you should do this, and they're not worried about it. I mean, we have patients who come to our practice, in our practice, very wide range. Certainly with non-Jewish women, Jewish women, but amongst the Jewish women, there's such a wide range of observance levels, from non-observant to Satmar Hasidim and everyone in between, if those are the bookends. And some women come and say, I'm not worried about this. I have no interest in doing this. And so we don't push them into testing or screening, because that's their business. They don't need to be, pushed into screening. Again, it's not going to make her healthier. It's not going to make the baby healthier. If she had pneumonia and I recommended antibiotics and she said, no, I don't think so, I would be like, well, you're out of your mind. Like, of course you should have antibiotics, but we don't do that for things like genetic screening. And the other thing which is interesting is a lot of women they spend so much time reasoning their way into or out of testing and bringing up this idea of abortion, saying, since I don't think I would have an abortion, therefore, why would I take any risk and do an amnio? Therefore, why would I screen? And so I'm not going to screen. And they start doing this whole mental exercise about what would I do were my baby to have this, abnormality, which drives them crazy. And I just don't think it's a necessary part of the conversation, A, because it's usually not relevant, and B, no one knows what they would do under those circumstances. They don't know how they're going to feel. They don't know how it's going to affect them psychologically. They don't know what the exact diagnosis might be and what the implications are and what they're going to learn. And to start researching every horrible thing that could come up on a test before you do it is not a good idea from a mental health perspective, that's for sure. And so I think that that's really reassuring to hear that you're in favor of women who are interested in doing, screening and even testing if they need to, or want to, I should say.
Yeah, there is an idea that I've heard that there's a Gemara that seems to say that you're better off not knowing certain things, because once you know them, they can't change. In other words, there's a Gemara that indicates this. The Gemara that says that if a person is measuring how much their harvest is, so until they don't. Before they've measured it, they can pray that it should be a lot. But once they've started measuring and they finish, they can't pray anymore, because then you know exactly how much it is. The bracha is only found on things that are hidden. So that's been taken to mean that, like, if you don't test the things, then maybe they won't happen. Now, that's clearly not true factually, and medically, it's certainly not true. If you have it, you have it. You don't. The test is not going to change anything, or it's only going to tell you what's there. There's another Gemara that says exactly the opposite, that you can't pray for the gender of a child, because it is what it is. In other words, it was already happened. Assuming, again, there's a whole thing in the first 40 days, but that leaving that aside, once a gender is decided, it's not going to change. So it's futile. You can't daven for anything and pray for anything that's futile. So that would seem to indicate that even though we don't know, in the time of the Talmud, they didn't know. They had no way of knowing the gender of the child. Still, once it was determined, that's it. So anything you can't do anything about, it is what it is. It is. So you can't, it won't get better. It won't get worse. So it's just going to be whatever it is.
Thank you both so much. I was going to say, we're going to hear the medical approach and the halachic approach. What I didn't anticipate was hearing also the emotional, psychological, and hashkafic approach to these issues. And I think those obviously need to be acknowledged, that they are significant anytime we talk about anyone's health, pregnancy, both the decisions that are made by the couple, by the woman. And it's very reassuring to know that both our medical practitioners and our halachic advisors are really giving us the full picture. So thank you both so much for that. Just another follow-up question. Since the questioner in the case mentioned the idea of the couple's opinion about abortion. I think, Dr. Fox, you referenced this a little bit. Do we think that the couple should have a clear sense of what they would each do in a situation where they were to find out that this pregnancy will result in a baby that has a significant challenge to life? Is it worth it for them to work out their issues? There are differences of opinion on abortion. Dr. Fox, you started this, so maybe you'll just finish up your thought and then we'll hear from Rabbi Ammon.
Yeah, in a situation like this, I would strongly discourage people from trying to sort that out at this time. I mean, that is a real tough issue to work out just internally amongst one person alone, let alone with somebody else. There's so much that goes into that type of discussion and decision. And if it's not going to be relevant, I wouldn't bring it up. Now, obviously, if results come back and you have to make a decision about what to do, it's important to do that. But I don't think I'll do it in advance unless there was such a strong suspicion on the front end that it's going to come back abnormal. Maybe it's time to start having preliminary conversations in the what if department. But otherwise, what ifs are a very tough thing in my line of work because it can lead to very dark places very quickly.
I agree with that. I what if not good? The only thing is if this itself, even before they do any testing, becomes a bone of contention in their marriage, then they may need marriage counseling. In other words, I think they may need a marriage counselor more than they need a rabbi or a physician at this point. They may.
Okay, thank you both. I think that that really covers the points we wanted to get across. And of course, if anyone has any follow-up questions, please feel free to send them in. I guess I'll just pose one more question about this, which is, Dr. Fox, from your perspective, at what age does your recommendation change? Is there a cutoff age? Like in our case, Leah is 27. Is there an age at which you would change your recommendation as far as like where there are no longer 3 equal options, but things begin to change?
Yeah, it's a really good question, and it's good for 2 reasons. Number one, because it is quite valid because of the way risk changes over the course of age, but also more importantly, because historically, women were told different things based on their age. And so many women come into pregnancy with this they're pre-educated about genetics, but unfortunately it's outdated. So what used to happen was, this is going all the way back to the 70s and early 80s, there used to be no screening tests whatsoever for Down syndrome. There was no blood test, there was no ultrasound, there was nothing. All that we had was an amniocentesis. You did it or you didn't do it. And at the time, the risk, it was still thought to be low, but it was more like 1 in 200. That was the thought. So the question is, who should we do amnios on? Should we do it on everybody? Should we do it on nobody? And what has been known for many, many years is as women get older, the likelihood of the baby having certain genetic abnormalities, most famously the ones like Down syndrome, though there are others, that's the most famous one, that risk increases with age. And so what happened was the doctors at the time trying to sort this out made a decision saying, okay, when you're under 35 years old, your risk of Down syndrome is lower than 1 in 200. It's 1 in 300, 1 in 400, 1 in 500, something. So if I was under 35 and I did an amnio, the likelihood of finding Down syndrome was lower than the likelihood of having a complication from the procedure. So overall, on balance, it wasn't worth doing. And if you're 35 years and over, the risk is 1 in 200 or higher. And so once you're in that age category, if you did an amnio, the chance of finding Down syndrome was higher than the chance of a complication. So based on that, there was a term that was made called advanced maternal age, which is horrifying to women who turn 35 and realize they're now advanced, whatever that means. And actually, the term that's used in medical coding is called elderly, which is lovely for someone to hear when they're 35. It's unfortunate, but that's the term that got thrown out there. And so women are sort of this opinion that, oh, since I'm 35, I have to do something. I have to do an amnio. And that's actually incorrect for 2 reasons. The first reason is it's incorrect on the face of it, because even though the risk might be higher for an amnio than having Down syndrome at age 30, what if a woman is much, much more concerned about having Down syndrome, a baby with Down syndrome, than having a miscarriage? I mean, she may value those 2 risks differently. Similarly, someone at age 40 maybe had a very difficult time with fertility. She had a hard time getting pregnant, her first pregnancy. And she's like, I don't want to take any risk of a miscarriage. I'd rather take a 1% risk of Down syndrome. And so it's not just mathematical. There's value that has to go into these things in order to make a determination. And the second thing is that it's really outdated, because nowadays with the screening tests that we have, these non-invasive screening tests like the ultrasound and the blood test, they take into account the woman's risk from her age. So if a 25-year-old gets a result that says your risk of Down syndrome is 1 in 5,000, and a 40-year-old gets a risk 1 in 5,000, they're both 1 in 5,000. They're the same risk. So, like what weighs more, a ton of feathers or a ton of bricks? It's the same. So it's the same thing here. When we give them the number, the age is included in it. And so it's not as relevant anymore as it once was. And so I actually don't counsel women differently based on their age. I have the same 3 options. The only difference is what is her risk if she doesn't do any testing or screening. What is the risk of the baby being born with one of these conditions? And it goes up as she gets older, and that may influence her decision about what to do.
Okay, great. Thank you. I will say personally, I appreciate your acknowledgement of the mini trauma that a woman sees when I remember it very clearly the day that they brought my file into the office, and in big black Sharpie on the top of the folder was an AMA.
Oh, that's so kind. That's just wonderful kindness. When you're 34 years, 11 months, and 31 days and younger, you're fine. At 35, it's all over. Yeah, it's unfortunate. We try to really downplay that a lot and try not to bring it up too much. I remember when I turned 35, I know I'm not, getting pregnant, but it was still like, oh, there I am. I'm in the new category.
I think for a lot of people, 35 is not an age that causes a tremendous amount of trauma. But when you see that your doctor thinks you now have entered a new stage of life, it shakes you up a little bit. So thank you for your sensitivity.
Yeah, that's on us. Our fault. Our bad.
Rabbi Alman, do you want
to? I'm sorry.
Do you want to add anything to what Dr. Fox said? Is it just
No, I don't think. I don't think from a halakhic perspective it really changes anything, except, again, obviously the greater the risk of having something that would militate more again. But it also, again, the woman's anxiety level is very much very much important in this. A person who feels more anxious should maybe test more than one who doesn't. That clearly plays a role. Okay,
perfect. Thank you. Always good to hear from our rabbinic leaders that halacha takes mental health and things like anxiety into account. Okay, let's look at our second case. Esther is a 36-year-old woman who is 20 weeks pregnant with her 5th child. Esther and her husband, Aaron, upon the advice from the rabbi who married them, did not do any genetic screening or testing in any of her other pregnancies, as they are strictly Orthodox and would not terminate a pregnancy under any circumstances. Today, Esther had a routine fetal anatomy ultrasound, and several abnormalities were seen. Things like congenital heart defect, clenched hands, low weight. The doctor was concerned this fetus has trisomy 18 and is recommending an amniocentesis to confirm. So Dr. Fox, you had started the conversation a little bit about amnio. How would you advise this couple now?
Right, so this is a different situation. Here we're not talking about screening anymore to look for something that wasn't otherwise suspected. This is a situation where someone comes in, and this unfortunately does happen, I don't want to say too commonly, in any individual person it's not that common, but in a big practice we have this situation a lot. Where a woman did not have any screening, so there's no sort of information coming into the pregnancy or into this situation, and there is a suspicion that the baby has a genetic abnormality. When we do an ultrasound and look at the baby head to toe, most of the time everything looks normal, and then maybe let's say 3% of the time, 5% of the time, we'll find something that's there, and we talk about it, but we say, it's probably nothing, everything's gonna be okay, and sort of we find something, but mostly reassuring. But periodically we see things that are quite concerning. Either directly, meaning like a heart abnormality is itself an issue, but also that could suggest that there is a genetic syndrome that's sort of overlying all of this. And the things that are suspicious to us, that make us suspicious of that, if there's multiple abnormalities or if they fit certain patterns that are classically associated. So this pattern is one that is classically associated with trisomy 18, which, like Down syndrome, is a condition where there's an extra chromosome in every cell in the fetus. It's the 18th chromosome instead of the 21st, which is Down syndrome. It does happen more commonly as women get older, like trisomy 21. But unlike trisomy 21 or Down syndrome, pretty much everybody on this conference either knows somebody or has seen somebody or has met somebody with Down syndrome. Very few people have known somebody or met somebody with trisomy 18, because the majority of them do not survive either to birth or they don't survive after birth. There are some babies that survive after birth, but generally not. And these, unless they're what we call the mosaic, they typically have very little quality of life. There's not universally, but typically. And so in that situation, we're dealing with a woman is carrying a pregnancy and a child who is likely going to have a genetic condition that could be very, very difficult for that child and for that family. And so in that situation, we're not talking about screening, we're talking about testing. And so when the doctor recommends an amniocentesis, that's to confirm, is this a baby that has that genetic syndrome? Or is this just a baby that has a heart abnormality and maybe something with the hands, which is a much different prognosis overall, because if it's a heart abnormality, sometimes they can be corrected with surgery, and then the prognosis is based on the heart abnormality itself, and it has its own set of prognoses. But if it's a genetic abnormality, it's bigger, so to speak, than the heart. And we generally do encourage women to have an amniocentesis in that circumstance, even if they didn't do genetic screening, and even if they wouldn't normally terminate a pregnancy, or even if they won't terminate the pregnancy if it confirms trisomy 18, because number one, sometimes women who would not ordinarily terminate a pregnancy, or in the case of certain women whose rabbis won't allow them to normally terminate a pregnancy, in a situation like this might, if the condition is considered to be lethal or severe enough, and she's going to have either a lot of emotional distress, or potentially the pregnancy itself might be dangerous to her. She has certain medical conditions, or she's going to have a C-section or something. They might agree to terminate. But even if not, there's also ramifications in terms of what would we do if the baby looks very sick at the end of pregnancy? Would we do an emergency cesarean or not? And you wouldn't if the baby has a condition where we expect the baby not to survive. And so it's a much different situation. And frequently this happens with people who did not have any genetic screening and then are left, what do I do in this situation? And it's a time when frequently people who wouldn't normally do an amniocentesis have to make a decision and get their rabbis involved, particularly if they didn't do genetic screening because they were advised by their rabbi.
Okay, thank you. This is where things are very difficult and emotional. Rabbi Amin, if you would be able to address for us, I'm sure you have points you also want to address on your own, but just some of the things that Dr. Fox mentioned about the risks at play that a Rav would consider in rendering a decision or in helping a couple come to a decision, as far as the criteria that would come up: the mother's health, physical health, the mother's mental health, as well as a condition that is maybe not compatible with life or is likely to result in a very low quality of life. How do those things weigh into a halachic decision?
Yeah, so the whole thing is a very, very difficult situation. Now, I would say I found it very fascinating what Dr. Fox said, that one reason to have the amniocentesis in this case is because maybe it may not be trisomy 18 and it may just be a heart defect, in which case something can be done about it. Would that mean that they would do surgery while still in utero, or they would wait for the birth, or it could be sometimes one way, sometimes the other way?
Almost never are there surgeries we can do in utero. Very, very, very rare circumstances where we intervene. They get a lot of press when that happens, but you're talking almost.
That's not the norm. That's not
the norm. The norm is you would sort of say, okay, what is the heart defect? What exactly is going on? Who's going to be the cardiologist? Who might be the cardiac surgeon, and deliver and have a plan in place for after birth, which is important because it improves the outcome if you know what you're going to do before the baby's born, such that when the baby's born, everyone's ready and on standby versus just finding out at birth. So that has a lot of value, even though you're not, quote unquote, fixing it during pregnancy.
So it still could have value doing it. Of course, one could say, look, if nothing is going to be done now, assuming a couple is adamantly not going to terminate the pregnancy no matter what, so then to my mind, I would be less inclined to push them to do the testing. Certainly, if they want to do the testing, I would see no reason why they can't do it. I would see no reason why they ought not do it, because again, if it'll prepare them in any way for what the results would be, fine, that's good. On the other hand, if they prefer not to know and they'll wait till the baby is born, why do they have to? Why should they live for 2 months more with a bad result if they don't have to? I don't know that I would push them to do it. I would just say, though, you have to, obviously, the hospital would be apprised of this situation and know that there may be surgery that may be necessary afterwards, at this point. But I don't know, unless you'll tell me that that definitely would impact upon the care of the baby significantly, whether the test is done or not, I would tell them it's really up to them. If you're telling me that the hospital will only be willing to have a surgeon standing by if they knew definitely that this was an issue, then I would tell them certainly have the test.
So it's interesting. You mentioned about the baby. It could impact the care of the baby. It is possible that surgeons would decide, I'm not going to operate if the baby has trisomy 18. They think it's unethical. That's actually a debate about whether it is or isn't unethical to operate on these babies with heart defects who have trisomy 18. Again, different for trisomy 21 Down syndrome. Everyone would operate on those babies because their quality of life is much different. But the interesting thing is it's actually an issue with the health of the mother, which changes in a circumstance like this, because and this is frequently a conversation that I have with the parents and often with the rabbi, if it's sort of, because these things often get lost in translation. And what I'll say to either them or to the rabbi if they want, it's not going to affect the mother's health directly if she knows whether the baby does or doesn't have trisomy 18. It certainly could affect her mental health, for better or worse, obviously. But one of the main things is if I don't know whether the baby has a genetic abnormality or not, what might happen and frequently happens at the end of pregnancy is, she's 36 weeks pregnant and the baby's heart rate is dropping. And in a normal circumstance, I would say, oh my God, the baby's heart rate is dropping. I'm concerned. I need to intervene. This baby might die inside. I'm going to go rush you to the back and do an emergency cesarean to quote unquote save the baby, which I would do. But if I knew the baby had trisomy 18 and I was certain of it, meaning I wasn't just guessing, but I knew that, then I wouldn't. You would actually let the baby, unfortunately, pass inside, because that's what's going to happen probably after birth. And to subject her to major surgery would be quite unfortunate for a baby with trisomy 18, unless that's what she wanted, so to speak, so she can hold the baby before he or she dies, which some women do. But that changes her care during pregnancy. So it usually has little relevance for the baby's care. It could, but it frequently has relevance for her care. And that's why these things get so different from what they were expecting.
So with that medical knowledge, you see, this is why it's so important for rabbis to speak to doctors. With that medical knowledge, I think it would be I would be much more likely to advise a mother to have the testing under all cases, no matter what she decides about termination, because it could make differences in other cases. It could make differences in other, like what you're pointing out. So that's one aspect of it. Then, of course, one gets to the whole issue of the halakhic view on terminating pregnancy. So let me address that, because that's really, sort of what we're dancing around in a sense over here. And this is that really it boils down to some degree to how one views the status of the fetus, how one views such a status. There's an old joke, but I guess it's worth repeating, that a rabbi, a priest, and a minister are debating when life begins. So the minister says, the Catholic priest says it begins at conception, and the Protestant minister says it begins at birth, and the rabbi says it begins when the kids go to camp. But the bottom line is that there is a debate as to when life really begins, what we view the fetus as. And it's not there's no simple answer to it. There appear to have been two different opinions about this for quite a bit of time. Going back to our medieval literature, there are indications in the Talmud contradicting indications as to whether a fetus is considered a life, is not considered a life, and so therefore, while it's true, I would say that today the view that is predominant among the poskim is that abortion, terminating a pregnancy, is considered a form of murder. Not everyone agrees with that. there is I would put it as a very significant, I call it a minority opinion, but it's another opinion that that it is not considered murder at all. And the big difference is, if it is considered murder, we're only going to permit it to save the life of the mother. We're not going to put it. That's clear. You see, this is a funny thing. I mean, if it's murder, how can you permit it to save the life of a mother? But that's clear from the Talmud that that is definitely permitted, and there's no question about that. One can definitely terminate a pregnancy to save the mother's life. There's no question about that. But short of that, if it's a question of just psychological issues of sorrow, of having to deal with the consequences of having, let's say, a Down syndrome child, which again can be devastating to the family and to the parents, and they may, they may want to do that or not want to do that, but definitely it has psychological, and it can create all kinds of trauma for people. So here it would depend on these two views, because if it's really murder, you're not going to permit it. If it's not murder, it's just something that's normally considered unwarranted, then for the benefit of the family, for the benefit of the mother, we might permit it. Now, there's I once heard the following rather unbelievable story, which again, it's a story, but I think it tells us something about this entire issue. Rosh Shlomo Zalman Auerbach, who was one of the prominent poskim in Yerushalayim and in all of Eretz Yisrael, he passed away. Now it must be, I guess, about 15, 20. I'm very bad with the years, but some time ago, he was staunchly opposed to terminating pregnancies, again, unless the life of the mother was in danger, as was Rav Moshe Feinstein here in America. They both took the stringent view. Nonetheless, Rosh Shlomo Zalman Auerbach was very friendly and very close with another great posek in Yerushalayim, Rav Eliezer Waldenberg, who was the rabbi of the Shaarei Tzedek Hospital. And Rabbi Waldenberg had a more permissive view towards terminating pregnancies. Whenever there's great psychological stress on the mother or the family, he permitted it. So when people would come to Rosh Shlomo Zalman with very difficult cases, he would sometimes say to them, "Why are you asking me? Go and ask Rav Waldenberg." In other words, he would refer them to the rabbi who he knew would give a permissive answer, even though he wouldn't. So his students said to him, "But Rebbe, if you feel that it's murder, how are you allowed to tell them to go to someone who's going to permit it if you really believe it's murder?" So he said, "Look, a lot of these cases, again, there's stress to the mother. It's very hard for me. Do I know, does this fall in the realm of pikuach nefesh for the mother? Because severe depression is also pikuach nefesh. That can be pikuach nefesh too. So I don't, it's very, very, how could I make these decisions?" So if Rav Waldenberg is willing to consider it not murder, let him decide it. And it's fine if he'll decide it, because it could be that I would really decide the same way too. It's just much harder for me to do it, because I have to weigh and figure out something which is almost impossible to do. So it shows you, on the one, it shows you, first of all, the mutual respect of the certainly the respect Rosh Shlomo Zalman had for Rav Waldenberg. And also it showed you his sensitivity, that he felt, look, there's certain cases where it's clear that there's a need for it. It's just harder, according to my criteria, to determine it than it is according to his. But the bottom line is that a lot of cases where there can be when there can end up being trauma in a family, where it can be terribly devastating to the fabric of the family, these could all be good grounds for terminating, even if one does take the strict point of view. Now, a case of trisomy of 18 may be a little different, because if you're saying that most of the children don't live at all, or live very, very shortly after they're born, in a sense, there's less stress on the family. But on the other hand, there's more grounds to argue that it's not murder, because the fetus is not something which could live anyway, so it may not be considered murder in that regard. That's possible too. Now, I also want to point out on the other side of the coin is that years ago I had a situation where a couple came to me, and there was the possibility that the child was trisomy 18, and I advised them that they should test and they should find out and whatever. But even after they found out it was confirmed was going to be a trisomy 18 baby, they did not want to terminate the pregnancy, and they didn't. And they had the baby. The baby was born. The baby lived a few months. During that time, after the baby was born, there was a need for some further surgery, and they opted not to do the surgery at that point. With rabbinic input, they opted not to do the surgery, but they were very, very, they consider it almost like a privilege that they had this baby. They felt just that this baby was part of their life. they held the baby. The baby came home from the hospital, was home for a month or two. I don't remember exactly how long, more than a month, definitely more than a month. And when the baby died, they sat shiva, and it just made them feel, and they consider that part of their, part of their family, part of their experiences with their other children, etc. And so I think for them, it probably was the right decision, even though most other people would not have opted for this. I think for this particular family, it ended up that it really was a valuable experience for them. So there's no one answer to this. There's definitely no one answer.
Yeah, I think that's been my experience as well. And I want to touch on two things that you said, which were so poignant. In terms of what you said about the family that chose to have the baby with trisomy 18 and found meaning in that experience, in that birth and having the baby, that's absolutely true. There are many women, many families who get, unfortunately, they find out their baby has a diagnosis that's lethal, and they choose not to terminate. And that's obviously the right decision for them and their family. And like you said, many women, they want to hold the baby after birth. They want to, to parent that child until the baby passes away. And that's going to ultimately, in the long run, maybe bring them the most comfort over this horrible situation versus a termination. And other women feel differently. They say, if I deliver this baby, I'm going to be so traumatized by having a newborn that dies versus having a termination, and they feel the other way. And that is why there isn't one answer for any person. There's so much of this that's very personal in terms of what is going to affect her and the family. Again, psychologically, mental health wise, physically, obviously, how do people, some people have very easy pregnancies, some people have very difficult pregnancies. These are all part of it. And the other thing you mentioned about the sensitivity of the rabbis that you were referring to. And, in my experience, I in my line of work, I speak to a lot of rabbis, and like all people, all of us are, have wonderful, strengths and weaknesses. And some rabbis are very, very experienced with medical situations, particularly pregnancy, and others aren't. We find that some people are more experienced, but the ones that are really, really good, who I speak to, you'd be surprised how wide their opinions will go. I mean, I speak to Hasidic Rebbes who, in a million years, these, their followers, the people who are in their sect, don't do any genetic testing, don't do anything. They would never terminate this or this. And then when a situation comes up and I get on the phone with them, and these are people who are very wise and a lot of experience, and I tell them the situation, you would be very surprised what happens under some of those circumstances with women who you never think. Again, it doesn't mean they're going to terminate the pregnancy. Some do, some don't, but their consideration is wide, and it's very impressive. Others don't have that experience and don't have that wherewithal to be. So you really have to make sure, if you're going to seek out a rabbinic opinion, obviously it should be someone you trust, but also you want to be sure that this rabbi has experience in medical decisions. And if he doesn't, he should also be saying, I don't have a lot of experience in this. I'm going to bump it up to somebody that I ask questions to, because that's really important. Because there are people who know a tremendous amount about this. I speak to them. It's like speaking to a colleague medically. They know all the right questions. They know the details. They know the genetics. They know the anatomy. I mean, they know so much. And these conversations are at such a high level where they can really provide good advice and just counseling to that family about what to do in that circumstance.
It also is, again, as I mentioned before, imperative that the rabbi speak to the doctor, because you have to really know what's going on in case. You can't just, the family may not even understand always all the things involved, because they might not have heard it correctly from the doctor. They may have missed something in the translation. I think it's very important for the rabbis to speak directly to the doctors.
I mean, I'm emailing rabbis ultrasound reports and images and genetic screen results. I mean, those who know, they know what to look for and they know what to ask. And I agree that they need the information. And a conversation is obviously the best way to do it, but sometimes everyone's, doing 100 things at once. But to get as much information as they would need from the doctor is critical in these situations.
Thank you both so much for addressing a very difficult topic, not just with your expertise, but also with your sensitivity. I think, Dr. Fox, one of the things you said about getting rabbinic advice is that you also use the word counsel. And I think that's a really significant piece of this, is that, of course, there's a halachic angle that we take into account, but very often the job of a rabbi is also to be there, and of the doctor as well, is to be there as a, holding hands and counseling and recognizing that whether the answer is termination from a medical or halachic perspective, or is to have that child that regardless, there's going to be some serious mental health repercussions, some very emotional decisions to be made, so that couples need a lot of support in this area, and we certainly hope that they will get it. I think your patients are very lucky that not only do they have you as a medical guide, but you can also perhaps suggest to them some rabbinic leadership that they can seek out in certain situations. So
I try not to. Those are waters I try not to.
You make rabbinic referrals.
People ask me, what rabbi should I speak to? I was like, well, it depends what answer you want. No, it's I try not to do too much of that, because it's I don't want to, the fact that I'm Jewish, the fact that I'm, Orthodox, that means different things to different people, and to some people I'm to the right of them, and to some people I'm to the left of them, and I don't want to be pushing my agenda on that. I don't have an agenda, but if I did, I don't want it to be seen that I'm pushing it on them. Sometimes it's just helpful that I sort of understand the issues that are coming up. I understand the concerns that they have, but it doesn't, honestly, my practice, some of us are Jewish and religious, some of us are Jewish and not religious, some of us are not Jewish. And ultimately, the same principles apply. Everyone in our practice is comfortable speaking about these issues and speaking to rabbis, and the rabbis don't seek out, those of us who are, more observant than others, because it doesn't make a big difference. And, for us, like you said, just the idea of counseling is so critical. So much of what we're doing is not medicine. It's not statistics. It's really, interpersonal. We call it obstetrics and gynecology. I mean, it's what we do all the time. These are such difficult and charged situations. When everything's going great, it's easy. But when these things come up, it's not so much the medical side. It's how is someone going to handle this? This changes their whole life in a minute. And that's very hard for people to process. And it takes a lot of time, a lot of conversation, which is a good thing that it takes that much time. But it's very, very delicate, obviously.
Yeah, for sure. 100%. There's been a few questions about genetic screening preconception. So there is actually a session. I'm not sure if I think it's taking place tomorrow, actually. So for all of your preconception genetic testing questions, I see screening, he turned it into a verb. And as well as there are other organizations, of course, but Screen is a solid one where people can get that information. We encourage you to check out the session during our conference, as well as to avail yourselves of all of that information. In the few minutes that we have left, if either Rabbi Alman, Dr. Fox, if you want to just address how does whether a couple has had genetic counseling or screening, really, I should say, before they come to your office. You mentioned in this case where the couple has none. Right. But if you could just give us a little insight about that.
Yeah, I think it's important for people to realize that the genetic screening that's done before pregnancy or even before marriage in many cases is totally different. The genetic screening we do in pregnancy for the baby, like for Down syndrome, is specific to this pregnancy, this baby, right? Does this baby have a genetic condition? And so therefore you would do it every pregnancy if you're going to do it. The screening that's done before pregnancy or before marriage is to screen the parents, right? To screen who's going to be the mother, who's going to be the father, if they carry any genetic diseases. And those are things, for classically Tay-Sachs, or people who've heard of cystic fibrosis. And there's hundreds of these conditions. And it's different because those are conditions that are typically things you would not pick up during pregnancy. You can't test the baby for it with a blood test or an ultrasound. The only way to test the baby for it is to do like a CVS or an amniocentesis during pregnancy, or after birth test the baby. So the reason we do the screening before pregnancy, and you really only need to do it once because your genetics are not going to change in your lifetime. The only reason it's ever repeated is when they sort of advance a test to test for more things. It's to see which couples are at risk for having a baby with a specific condition. And if they are a couple at risk for that condition, they can make a decision ultimately, like from the very beginning, are we going to get married? If we're going to get married, are we going to have kids? If we're going to have kids, are we going to do IVF and test for it? Or are we going to sort of wait, get pregnant, test, during pregnancy, or wait till after the baby's born? But at least to make some sort of decision about what we're going to do if we're at risk. Fortunately, even though probably 50 to 80% of us carry something, the likelihood that a couple is going to carry the same thing, which is the only situation where it really matters, is 1% or less. And so it's a lot of screening that's done to just find that 1% of couples who are at risk for a specific thing. And then what are they going to do about it?
Okay, great. So even though this is not the preconception testing, if Rabbi Alman, if you could just address that last piece that Dr. Fox mentions about if it's really only about 1% of couples where it turns out they're a carrier for the same genetic disease, how do we advise as far as testing? Do we take that into account in halacha? Is that something you would advise couples to do?
Well, it's interesting. I don't know. You say it's only 1%, but I think that we've seen over the years, that sort of Tay-Sachs has been pretty much dramatically, I wouldn't say it's eliminated, but it's gotten much less since you have all this testing. So obviously the testing does make an impact that's sort of that you can see, that you can, that does make a difference. And so again, percentage wise, I don't know again, but it's certainly something that I think is something that people would be concerned about and would want to avoid. If you tell them, you can. Now the question is, again, depends what you're dealing with. If you're dealing with advising a couple whether they should or shouldn't get married, that's a very different decision than if you're advising a couple that already is married, whether now they should have a pregnancy through IVF or whatever to avoid whatever particular problems that they may have. So so that's already those are differences. But again, I think that I would be inclined to encourage people to be tested for these kind of things, because again, the test itself is non-invasive. It could prevent a lot of heartache later on, because maybe a small amount, but if you do have couples where they're both carriers, you have then in 1 in 4 generally. Is that correct? You have a 1 in 4 possibility of having something, and that's already a serious. So, I think there's very little downside to doing this testing.
Right.
What do you? Yeah.
Yeah, I mean, we do encourage people to do it, and we're much stronger about it because, again, unlike a situation where when you're testing for Down syndrome, they're already pregnant. It's already happening, right? You can't test someone before their pregnancy if their next pregnancy is going to have Down syndrome. It doesn't work like that. So they're already pregnant. They say, listen, I don't need to know. I'll wait till the baby's born. In this situation for carrier screening, there's things you can do before getting pregnant to avoid that condition. So that's why we're definitely more, not forceful, but sort of there's a stronger reason to do it. The people who don't end up doing it, almost all of them did a screen before they either started dating or got married, like Dory Schreim or something. So they're like, all right, we know that we're not carriers of the same, whatever, how many, they got tested for 8, 10, 12 of the big ones. And the rest, the likelihood is so low, they don't want to deal with it. But ultimately, there's much more logic in terms of having everybody screened for these pre-pregnancy, for these genetic screens for carrier screening than there would be for the Down syndrome screening, because you can prevent it potentially.
Right. I agree. Prevention. Yeah. And it's a relatively, again, when you do get involved in having to, a couple might say, well, then I'm going to have all my children get through IVF. I don't want that. I'd rather not know anything. But again, I think it's somewhat of a silly attitude, because bottom line is, I think the risk, the tsaros you'll have with having such a child outweighs any benefit you'd have not having it through IVF. So I think that most people would make the decision, or if they understood the facts properly, I think would make the decision that they should screen.
Unless it depends on the condition, though. There are some conditions that are on this panel that the babies aren't really particularly sick. There's just sort of things you have to give them a different diet or this, and then some people will be like, all right, and there's actually debate whether those things should be on the panel or not, and there's a lot of different opinions of what conditions they ideally serious ones, but other ones sneak in somehow.
Yeah. But the things that could cause problems, I would think so. Yeah.
Agreed.
Okay, thank you. But I just have one last question to Dr. Fox, and then I might throw one back at Rabbi Alman right before we sign off here. The question is, the questioner says 25, but I think they mean 35. Why is 35 the cutoff for advanced maternal age? Why isn't it?
It's literally, it's a line in the sand. There's nothing about 35. Nothing happens physiologically when you turn 35. Meaning it's not like suddenly, your risk goes up. Meaning if you look at the risk by age, it goes up a little bit each year. And it continues. It's not like at 35, it shoots up. So it was only chosen because at 35, the risk of Down syndrome is about 1 in 200. And the risk of an amnio was thought to be 1 in 200. So that's where those lines cross on the graph. That's the only reason 35 was chosen. Nothing magical about 35.
Okay, perfect. Thank you for that. And Rabbi Alman, I just had one follow-up question, and talking about pregnancy termination, which obviously is very difficult, emotional and medical and halachic decision. But is there a time where you feel as a Rav, if a couple is adamant that they do not want to consider termination, but it's your understanding from a medical perspective that the condition is not compatible with life or there is any risk to the mother, would you feel it's your responsibility to suggest it to them or to advocate pregnancy termination?
If there was risk to the mother, again, if there's risk to the mother, then I would push for it. If there's no risk to the mother, I mean, no risk more than in any other pregnancy, then I would respect their wishes. Even if it's a pregnancy that can't result in a real viable life, but that I would respect that decision.
Okay, and Dr. Fox, do you feel the same way?
Yeah, I think in a situation where we know the baby's not going to survive, and we have this situation where it comes up where babies have lethal conditions, and not everyone chooses to terminate, and we really don't push them. Again, if her life were at risk, but fortunately that's pretty rare, and ultimately it boils down to usually either typical pregnancy risks, like Rabbi Alman was saying, or mental health. And if her mental health is going to be worsened by doing a termination, then I certainly wouldn't push her into it. In fact, I would think she's making the right decision to continue and deliver the baby. On the other hand, if her mental health is going to be significantly impacted in the other direction, then that's a situation where typically she's going to terminate. And many women don't seek rabbinical opinions on these situations. They just know what they're going to do, and others do seek, and and who they ask, and then that situation. But typically, if it's not compatible with life, most of the rabbis we've worked with, and pretty much all sects, are going to be okay with her terminating if it's going to cause her much distress, which is frequently the case.
Right. Okay. That about takes us to 2:00. So I just really want to thank both of you for not just sharing your wisdom and information that you both have so easily at your fingertips, but for doing so in such a sensitive way that really, again, takes into account all aspects of both the couple and, of course, for the mother in particular, her mental, emotional, physical health. There is something that is very reassuring to know that there are so many people in both of your care. So I thank you both so much for being here with us today. And of course, I encourage everybody who tuned in for this session to tune in to some of the other sessions that address some of the topics that came up today: maternal mental health, things related to any type of genetic testing, including for cancer and preconception genetic testing, all of those things. There is much to be learned throughout the many days of this conference. So thank you to Rabbi Alman and to Dr. Fox, and thank you all for joining us.
Thank you. It's a pleasure to be here.
Thank you. Great moderating.
Thanks.
Okay, thank you both so much. That was excellent. So informative.
That's great. Good job.